APH, antepartum hemorrhage, during the pregnancy. Out of 100%, 31% because of placenta previa, 22% because of abruption placenta, 47% because of some unclassified reasons like show, cervicitis, trauma, vulvovaginal varicosity, genital tumors, and some genital infection may cause the APH and vasa previa. As you know, vasa previa is the condition that also occurs during the pregnancy. And in this condition, what happens? Fetal blood vessels, which are communicated with the placenta, they just lie over the internal cervical os. So once we will do the artificial rupture of the membrane, what will happen? There will be the sudden gush of the blood. Let's discuss one by one each and every cause. So first, placenta previa. Placenta previa, basically when placenta is partially or completely inserted in lower segment of the uterus, then the level is, it is a placenta previa. There are the different types of the placenta previa: type 1, type 2, type 3, and type 4. In type 1, what happened? When placenta is in lower segment, but lower edge does not reach the internal os. And while in type 2, when lower edge reaches but does not cover the internal os. Type 3, the placenta covers the internal os asymmetrically. It means not completely, partially it covers the internal os. And type 4, the placenta covers the internal os symmetrically, means it will cover completely internal os. Incidence of the placenta previa is 1 in 200 pregnancies. As I told you, it is common condition comparatively to abruption placenta. In this picture, you can see different rates of the placenta previa, or you can say types of the placenta previa. In type 1 and 2, if you see, placenta is not covering the internal os, though it is at lower uterine segment. It is just reaching at the level of the internal os, but not covering. At grade 3, placenta partially covering the internal os, and in grade 4, placenta is covering completely internal os. Again, in this picture, you can see type 1 low line, type 2 marginal, type 3 partial, and type 4 complete covering the internal os. Etiology of placenta previa is unknown, but more common in multiple pregnancy are women who had previous multiple pregnancies, abnormally developed uterus. If there are the chances patient may have placenta previa in ongoing pregnancy. And also placenta previa commonly seen in scarred uterus due to uterine surgeries are those patients who are having history of abortions, cesarean sections. In abortions, because of the multiple time of the DNAs, it may lead to the placenta previa. Cigarette smoking is also one of cause. Drug abuse, especially cocaine, also be one of the reason of placenta previa. Now, what are the effects of placenta previa? So maternal risks are, yes, there is risk of maternal mortality. Mother can die in this condition because in this condition, female develop heavy bleeding during pregnancy, even after the delivery of the baby, means after the cesarean section, because there are the multiple sinuses formation occurred at the lower segment of the uterus. As a result, patient may have PPH. So PPH caused by the inadequate occlusion of the sinuses of the lower segment, surgical and anesthetic complication due to inadequate preparation of the patient, postpartum sepsis that caused by the infection of the bed of the placenta, placenta accreta that occurs in up to 15% of women with previa, and risk of recurrence of this condition is 4 to 8%. Now, fetal risk. Yes, there's a risk of prematurity because if mother started to develop a heavy bleeding PV, then what will happen? We have to make a decision for the delivery and we will go for cesarean section and definitely baby will deliver before the time. Fetal growth restriction in 16%, especially if multiple episodes of bleeding. Incidence of malformation increases commonly of CNS, CVS, and respiratory as well as GIT. Other risks are prolapse and compression of the cord, anemia, malpresentation. So these all are the risks in the fetus. How patient presents to you? Presentation. Unprovoked painless vaginal bleeding. She will give you history of the bleeding period, but she will not have any kind of abdominal pain. Occasionally can be caused by this bleeding because of sexual intercourse. And as I told you, there will be no pain. So absence of pain is significant feature, but in 10% of cases, there is coexisting abruption or labor pains. Initial episode of bleeding usually occurs at approximately 34 weeks and before 36 weeks in 50% of cases. In abdominal findings are malpresentation, which is either reach or transverse in 35% cases. Obviously, when placenta will lie at lower segment, the baby will be unable to come in normal position. So whether you will find baby in transverse position or in reach position. Consistent deviation of the presenting part from midline, difficulty in palpating the presenting part. How will you diagnose this condition? We will not perform vaginal examination. Vaginal examination is deferred until ultrasonography has excluded the PREVIA, because once we do a vaginal examination, patient will start to bleed. So we will not perform in such cases vaginal examination. First, let's confirm the position of the placenta. Once in ultrasound it is confirmed that placenta is a low line, then we go for the perispeculum just to rule out or just to see how much patient is bleeding. So perispeculum examination we will do at first sight, ultrasound examination. Ultrasound examination, yes, it is a safe method, accurate, non-invasive method of choice, but the more earlier it is done, more likelihood of diagnosing of PREVIA. How to manage such type of a patient? Initial management includes obviously with history, then examination, then you will go for the investigation, and finally treatment. You will start to treat the patient. In history, you will ask about how much the bleeding, how much roughly you will estimate the loss of the bleeding, initiating factor, and also associated factors like might be sometime PREVIA may present along with abruption, so patient may have abdominal pain, or PREVIA may coexist with the preterm labor pain. So we will ask for the abdominal pain also, regular uterine contractions. Also, we will inquire about the history of ruptured membrane or previous episode of the bleeding. Gestational age, yes, about her last menstrual period, and if earlier any scan have been done, then we will inquire about it. Information about site of placenta from previous scan, information about fetal movement. So these all were in history, information. Now physical examination. You will assess both maternal and fetal condition. Obviously, you will check the blood pressure, pulse, respiratory rate. If there is any clinical evidence of shock, you will start to manage the patient first. And in abdominal examination, you will see height of fundus, lie and presentation of fetus, number of fetus, cardiac activity, or verbally you will inquire about any movement, any tenderness, uterine contractions. If patient is having tenderness there, so patient may have PREVIA along with abruption. But if there are the regular uterine contraction, it means patient with PREVIA present in you with complaint of labor pain, fetal labor pain. Vaginal examination is, I told you, not advisable. Only inspection of vulva to determine if the bleeding is continuing and the amount you will estimate. Testing and immediate management. What will you do? You will insert 2 whiteboard cannula, size is 14 French or 16. You will obtain the blood sample for complete blood count, for grouping purpose, random blood sugar, urea, creatinine, electrolytes, prothrombin time, and FETD, and you will take the sample for cross-matching. You will advise 4 packed cells, 6 FFPs, 6 platelets before performing the surgical procedure. I mean, for cesarean section, before proceeding it, you must have these are blood pads in your hand. You will give the IV fluids. You can give polite crystallite, or if patient is very anemic, too much loss is there, start with blood. Even sometimes there may need of ultras blood. You will catheterize the patient, do a scan to locate placenta and to exclude abruption. After initial management, one of the following conditions is likely to be present. Might be bleeding stopped, bleeding is continuing and is mild to moderate and not life-threatening, or bleeding is continuous, heavy and is life-threatening. Fetus is in distress regardless of bleeding pattern. Fetus is dead regardless of bleeding pattern. These are the different presentations you may find out any one of them during the emergency. So management options: if bleeding has stopped in placenta previa, perinatal mortality is directly related to the gestational age at delivery. As I told you, most of the time baby have a risk of prematurity because we make decision of delivery before the time and we see only the condition of mother. Previa is a painless, heavy bleeding loss condition in which mother can die. So if gestation is less than expectant and there is no bleeding more, bleeding has stopped and patient is not severely anemic, so admit the patient. Transfused is required to maintain hemoglobin above 10 grams. Give her dexamethasone antenatal steroid, and we will do day-to-day management for the patient. There is no need to hurry to deliver the patient because again there is a risk of prematurity. If mother is stable, then we will make this decision. Advantage: what will be the advantage of this management? More fetal maturity. With time, the minor degree of PREVIA resolved. What are the disadvantages? Long stay in hospital, obviously, day-to-day management we have to do for this patient. Away from family, financial burden. So despite expecting management, about 20% of females deliver before 32 weeks. Okay, even we do cooperate, but sometimes we don't achieve our own target up to the 37 weeks. Most of the time it has been seen that patient again delivered before 32 weeks. Second option, if bleeding is continuing but is neither profuse or life-threatening and gestation is more than 34 weeks after resuscitation, deliver the patient. Yes. So depending upon the type of the PREVIA, whether induced or cesarean. If it is a type 1 is actually, it will be a lower segment, but it will not cover it will not reach the internal cervical loss, even in a type 2. While in type 3 and 4, we cannot think for the even normal trial, we go for straightforward for cesarean section. Next, it is If it is a bleeding after premature separation of the normally sighted placenta, so this condition we call placental abruption. Placental abruption means when there is a premature separation of the normally sighted placenta. Incidence of this condition is from 0.49% to 1.8%. It can be concealed in 20 to 30%. It can be removed in 65 to 80%. Again, we also grade the placental abruption, grade 0, grade 1, and 2. In case of grade 0, patient will be asymptomatic with small placental clot. Grade 1, vaginal bleeding, uterine tectonic and tenderness, no sign of maternal shock or fetal distress. Grade 2, vaginal bleeding, no signs of maternal shock, fetal distress present. If external bleeding, uterine tectonic, persistent abdominal pain, maternal shock, fetal demise, water within 30%, this all can occur in case of the grade 1 or 2. Now, what are the reasons, causes? Yes, etiology is unknown in most of cases. Maybe history of direct trauma to abdomen or sudden decompression of the uterus, like in case of polyhydramnios by multiple pregnancy, or patient has gone through external Catholic virgin procedure. These are the reasons that may lead to the abruption. Yes, sometimes, but I must say most of the time we have found the patients who are having the preeclampsia, suddenly they develop also abruption placenta. And in case of protein C deficiency or thrombophilias or hypercholesterolemia, in such conditions also there are the chances patient may develop placental abruption. What are the maternal risks? Maternal mortality rate is about 1% due to a hemorrhage or because of DIC. Recurrence rate is 6% to 17% after one episode. As recurrence occur in case of PREVIA, similarly in case of abruption, there are the chances the patient is having previous history of the abruption placenta. So in this pregnancy, she may develop the abruption placenta. If she is having single episode of abruption placenta, 6 to 17% chances. But if she is having 2 episodes of the abruption placenta, then there are the risk of 25%. Patient may have hypovolemic shock, acute renal failure, DIC, fetal-maternal hemorrhage can lead to a basis sensitization in Rh negative women. Now, fetal risk. Perinatal mortality is 4.4 to 67%. More than 50% are stillbirths. Fetal growth restriction is reported in up to 80% of cases. So this condition is more deadly for fetus, not for mother. While placenta previa is more affect, mother compared to the fetus. Okay. Diagnosis. How will you diagnose abruption placenta? Based on clinical grounds, abdominal pain, vaginal bleeding, tenderness, uterine contraction. And sometimes patient presents to you in shock condition. How will you manage? Management again depends on the severity, associated complications, condition of the fetus, as well as condition of mother. It can be divided into immediate delivery, expectant management, management of complications. Immediate delivery depends on severity of the abruption. Fetus is alive or dead. If fetus is dead, vaginal delivery, but first maternal resuscitation is started. Artificial rupture of membrane is done to hasten onset of labor. If fetus is alive and major abruption, cesarean delivery to improve the outcomes after maternal resuscitation. In mild to moderate abruption, mode of delivery depends on condition of fetus, its presentation, and state of cervix. If there is an abnormal heart rate, immediate cesarean section. If vaginal delivery is decided, then continuous electronic fetal heart monitoring and CTG, you must continue it. Use prostaglandin to ripen cervix in mild cases of abruption. Amniotomy and augmentation will start. In case of expectant management, goal is to take fetus to as much as maturity as possible, considered only in cases of mild abruption, mild bleeding vaginally, localized abdominal pain, patient cardiovascularly, totally stable. Then we can make decision for the expectant management. Close fetal monitoring, again, there's a need to closely monitor the fetal heart rate. Timing of delivery depends on further bleeding, fetal condition, gestational age, and availability of neonatal placenta. Again, in case of abruption, as I told you earlier, patient may present to you in condition of shock. If she is in a condition of shock, you have to resuscitate first patient. You have to pass on both hands 14 size French IV telegram. You have to take out the sample, but also for arrangement of the cross-match blood, and then immediately you have to give fluids to the patient, and if needed, then give even uncrossed blood to the patient. Once you have resuscitated properly the patient, then you will make next decision of the delivery. Sometimes patient may present to you with DIC, and you know DIC is a condition in which multiple organ failure occurs. So such type of the patients we usually manage in ICU setup. And because of heavy loss, patient may develop acute ischemic necrosis of the kidney. Means he will present with you acute renal failure. There will be no she will be unable to pass urine. And once you will catheterize the patient, there will be no urine. And it will give you some hint that it could be because of heavy loss, or it could be because of acute renal failure. And PPH, yes, similarly like in PREVIA, abruption have a PPH, chances of PPH. So thank you very much. That's all about